Hi, everyone. Welcome back. I'm Dr. Samantha, the maternity mentor, and we're here again for one of our live Q&A sessions that we have every Monday at 9 p.m. Eastern Standard Time. This is our chance to interact with you live and answer your questions that you have put onto the chat. This is also your chance to ask me anything that you want to know. We're over on Facebook and Instagram for additional content, so those will get linked into the description. And we really appreciate if you like and subscribe to the channel. Liking and subscribing to the channel really helps me out as a content creator. Give me 1 second, guys, because I think I am having a little bit of a tech issue with YouTube. Okay, I'm going to start again because it lagged all of a sudden on YouTube. So, hi, I'm Dr. Samantha, the maternity mentor. I'm here for another one of our live Q&A sessions that we have every Monday at 9 p.m. Eastern Standard Time. This is my chance to answer any of the questions that you have both live in the chat. So please feel free to put anything you want into the chat for questions, as well as questions that you've asked on the videos. Please remember to follow us over on Facebook and Instagram for additional content. And please share the channel with your friends and family. And please like and subscribe. Subscribing to the channel really helps me out as a content creator. And also, for those of you who stick around till the end, I will give you a sneak peek at tomorrow's video. So I'm going to go ahead and get started because you guys asked me a ton of questions this week, which was very exciting. So I had a whole bunch of questions actually this week on my antibiotics video. This is one of my most popular videos because I think antibiotics are one of the most prescribed drugs during a pregnancy. And when women are pregnant, they're very nervous about taking meds because they're worried about the baby and the effects of that medication on the baby. What I very much stress, anybody who's watched a lot of my videos or been on the lives, is that I very much stress the fact that untreated and undiagnosed infections are one of the leading causes of like preterm birth and miscarriage, and as well as like small babies and stuff like that. So it's really important that you get your infections treated, and it's all infections. And unfortunately, during pregnancy, you are immunocompromised. So you're at higher risk for developing an infection. So if you're feeling ill, you need to go to your healthcare provider and let them check you out. Now, depending on where the infection might be, with vaginal infections being kind of the most common that we're really worried about, it depends on what we might prescribe. Viruses really don't respond to much meds. It's just treated homeopathically. Antibiotics are used for bacteria, and then we use antifungals for like yeast infections and the such. So it's really important for us to check you and to see how it's going and what's going on with you. So we have a couple questions. So the first question was, I was prescribed I can't ever say this, ofloxacin eardrops for an ear infection. Both my doctor and OBGYN have said it's safe for the baby because it's only a topical antibiotic. However, I'm still concerned because it falls under the fluoroquinolone category. Should I avoid taking this medication completely, or is the topical use safer for the baby? I know this video is old, but I love the advice, which is why I asked you. So this is a great one to get started. So fluoroquinolones are very much a medication that we are sometimes careful about. So they are linked to certain bad effects for actually moms and stuff because they have some higher risk. But there are some medications like Levaquin, which is used primarily for like pneumonia, is one of the meds that we can use. So it's one of the things that we try to look at. But when you're in pregnancy, we're a lot more careful. Now, that medication that they're referring to, it's an eardrop. So there are different routes of administration for a whole bunch of different stuff. We have tablets, which is what's most often prescribed. You also have IV medications that are going directly into the bloodstream. And then you have like eye drops, nasal sprays. You have also like eardrops. Okay. So this particular medication is a P3. So there's a rating scale. I use Thomas Hale's um, guide. He does the infant risk line for medications, and he's created a scale that judges the risk of different medications. So for example, the rating scale is P1, P2, and those are safe or probably safe for pregnancy. P3 is risk versus benefits. P4 and 5 are not safe. And the same categories apply for lactation. So this is a way for us to kind of gauge, and it takes into account half-life, molecule size, fat solubility, the safety profile for adults and children in general, animal studies. It takes it all together and aggregates it. So you would not want to use this medication orally if you could help it. It's a risk versus benefit. And definitely, it is not recommended for use for a urinary tract infection. However, I do agree with your doctor and OBGYN because eardrops are going to stay local. Maybe a tiny bit will get into systemic circulation. That means it'll get into the bloodstream, but not enough that it's really going to impact the baby. It's going to stay locally. Most eardrops do. Now, believe it or not, nose and eyes, those kinds of drops are actually a lot more worrisome because there's a lot more blood vessels in both of those places that the medication can get into your blood. So if you need this antibiotic because you have an ear infection, you definitely want to use it because believe it or not, ear infections can turn into bigger things. Now, the next question I got was, I'm 5 weeks pregnant and have suddenly developed a sore throat and fever. I'm worried and don't want to take medication that might hurt the baby. I have a low-grade fever of 99 degrees for 7 days now. I don't know what would be best for the child. I have low immunity and have always needed antibiotics to get better. Please suggest what I should do. So this is a great question as well. So one of the things that's happened is that we have had a lot of overuse of antibiotics in our country and really across the world. And this has created antibacterial resistance. So this means that the medications that we've developed to fight bacteria are actually not as effective as they used to be because the bacteria is getting stronger and it's learning how to adapt. So it's one of those things that you have to be really careful and mindful of. I can tell you that in my house, one of the things we don't use the alcohol rubs. We don't use antibacterial soap because those things are actually not good for your immune system because it's exposing you to more and more things that basically decrease your immune system. Now, it's tricky when you're pregnant because if you just have a virus, which can give you a fever, which can give you sore throat and stuff like that, you definitely have to, take it with a grain of salt. Like antibiotics are not going to help that. However, we are worried about fever and pregnancy because we want to make sure we know what we're treating. We also are worried if you are definitely more prone to developing more serious illness. So while you guys might get a virus, which really can't be treated with antibiotics, you kind of have to go homeopathic. Really, you can't use much of anything. You can use saline nasal spray, the whole chicken soup. You can do a little bit of like the menthol rub or menthol inhalation, but there's not much you can do. But that fever can be an issue. So you want to contact your healthcare provider because they may want you to take antibiotics because they're worried that it's converting to pneumonia. A lot of viral infections can turn into pneumonia very easily. And as a pregnant person, you have a decreased immune system. And so a lot of people don't realize that. But in pregnancy, if our immune system was going full-fledged, it might go after the baby that is oftentimes considered a foreign body. So one of the things that happens is that we need to make sure, our bodies need to make sure we protect the baby. This is why with that reduced immunity, all of you guys probably know if you guys haven't been pregnant and sick, you will be pregnant and sick. I'm sure you've heard about your friends. Everybody gets sick during pregnancy. This is the other reason why we stress vaccines. The flu vaccine and the COVID vaccine are stressed during pregnancy because women are at higher risk during pregnancy for severe illness. And women are much more likely to be hospitalized for flu or COVID than the average person. And I have taken care of a number of flu and COVID patients in my career. So it really is a very true statement. So, and the reason why this happens is because of the decreased immunity. So everything that's happening, you do have to take it seriously. So call your healthcare provider if you're not sure. The next one I got was, can metronidazole be used for 2 days at 22 weeks of pregnancy? Will it affect fetal health? So I swear every week I get a question about metronidazole. Somebody somewhere put some really nasty stuff on the internet about it, and everybody is scared to death of it. I have seen metronidazole used so many times. It is used to treat some very serious infections that are very well known to cause miscarriage and preterm birth. And it's the one that's effective for those infections. So yes, you can use metronidazole, and especially since it can be used for just a short period of time. It's not something that you have to use long term. So two times is not a big deal. So the next thing is, I have a urinary tract infection and my doctor gave me Coamoxclav. I'm 11 weeks and 4 days pregnant, but I think this medicine has side effects like vomiting, headache, nausea, and diarrhea. Is it safe even with these side effects? So first of all, when we do studies on like medications, one of the things that happens is that they have to report any side effects that are reported by any of the study participants. So what happens is most drugs can cause nausea, vomiting, diarrhea. That is very, very common. So it's important that you know that not everything's going to do that. But antibiotics tend to be more likely to do that. Why? Because you have normal bacterial flora in your gut. That is there for a reason. And that bacterial flora, it helps keep us from feeling those things and getting like diarrhea and stuff like that. When we take an antibiotic, it kills it all off, and then we're left feeling really bad. One of the things you can do to help with this is to take a probiotic. Probiotics are fantastic for dealing with that kind of nausea and vomiting and stuff from an antibiotic. It replaces some of that good bacteria, and that can help. But ultimately, you have a urinary tract infection. And what a lot of people don't realize, urinary tract infections are extremely serious. So there's a couple reasons why. So urinary tract infection happens because your bladder, it's dark and warm and moist, and there's bacteria in your urine. So it sits up in there, and it ends up like growing like crazy. And unfortunately, when you're pregnant, you can't always pee out all the urine, so it just sits there. That creates the urinary tract infection. That can lead to uterine irritability, which starts contractions. Now, the second thing is, if left untreated, that bacterial infection travels to the kidneys. So you have two ureters, and they go to your kidneys. Now, your kidneys are very vascular. That means they have a lot of blood flow in them. And if you get an infection in the kidney, which is called pyelonephritis, that can turn into an even more serious infection called sepsis. Sepsis is a blood infection that affects the organs and can lead to actually organ failure and death. So this is why, going all the way back to that urinary tract infection, it's so important it gets treated right away. Those side effects are probably going to be mild if they happen at all. They can be managed, and it's definitely more important to get that infection treated than to potentially have that issue. So I have a question in the chat. Is yellow discharge normal during second trimester? It happens after I take prenatals. So thank you, Ronnie, for asking that, and welcome. So yellow discharge is not normal. Okay. That being said, I'm not going to say that it means that you definitely have an infection. So I have actually seen people's urine turn green from procardia. Procardia is a blood pressure medication that we sometimes give to women. So that can happen. If you eat too much squash, your stool can turn orange. So there are different color changes that can happen, but it just depends on what's going on. So yellow discharge after prenatals, maybe it is your prenatal, but yellow discharge in general is considered an infection. And because it is considered an infection, most of the time, like we would test you for an infection and treat it, you need to go get tested. You need to make sure that's not what's going on. So it's super easy. You go and they're going to do a vaginal exam and they're going to swab some of that discharge and they're going to send it to a lab. And in the lab, they can determine what's going on and if you need treatment. Again, it could be your prenatal vitamin, but you never want to ignore yellow discharge. And we actually have a video on like the different colors of bleeding and discharge. I would urge you guys to take a look at it because it is really important to know what's normal and not. We had another one, speaking of discharge, a question that said, I have discharge like cottage cheese with no smell and no itching. What could this be? So the thing is, I'm sure part of the reason why this question came up because cottage cheese type discharge, that is actually very common with a yeast infection. But yeast infections usually also have a lot of itching. So this kind of goes against each other. And I'm sure this viewer is like, wait, what's going on here? Not everybody has itching with a yeast infection. That does not occur across the board. The discharge is also not across the board. Some people have it, some people don't. So it's very, very important that you understand that everybody's a little bit different in how they present with different infections. You want to get discharge swabbed. That's what's the most important thing. We can't tell what it is if we don't do that exam. And that exam is the most important thing. But most likely cottage cheese type of discharge, it's probably a yeast infection. So it probably needs to be treated. And any of you guys who get a yeast infection, you can't just take over-the-counter remedies for that, just so you know. Those remedies, they need to be approved by your healthcare provider because believe it or not every single one of them is safe. You can't just pick stuff up off the shelf. Any of you joining me, please feel free to put your questions into the chat and I will answer them. I had a really great question from a viewer on my bed rest video. It was fantastic. I think I might actually make a video about this. So she says, I had cervical cancer and 3 cone biopsies. I'll need a cerclage and full bed rest after 13 weeks. I'm very worried about not getting any exercise or movement for such a long time. Do you have any advice on how to move while in the bed? So this is a great question. And I wonder if she's seen the bed rest video because one of the things I talk about is that bed rest is not always ideal. You should not be on bed rest unless your healthcare provider has told you need to be on bed rest. And then bed rest looks different for everybody. Some people, they can actually walk around their house and actually stand for 30 minutes at a time. They can stand for up to 2 hours a day. And other people, they can't even get out of the bed to go to the bathroom. They have to use a bedpan. So everybody is different as to what it looks like. But one of the reasons why bed rest is not always good is it puts you at risk for pneumonia and blood clots. So let's start with blood clots. You are at a higher risk in general as a pregnant person for blood clots. That's because you have an increased amount of clotting factors in your blood. And the reason why these clotting factors are there is they help prevent you from bleeding. And it becomes really important when it's time for you to deliver because we don't want you to bleed out all over the place during delivery. So that's why they're there. They're there to help protect you. But in the meantime, they put you at risk. So that's why they tell you you can't drive in a car for more than 2 hours. You have to walk around on a plane. Like that's why they're telling you this stuff. It's to prevent blood clots. Now, when you're on bed rest, you're not moving around, which means that's going to be an increased risk. In the hospital, we actually use something called SCDs. They're sequential compression devices. That's what they are. And they're basically these they put a cover that's like on your shin, and it blows up like a balloon and then it releases. And then it blows up like a balloon and it releases. And it's trying to mimic the muscular movement of what it would be if you were walking around. And it's used to help circulate blood and help to prevent blood clots. I would definitely say that if you know you're going to be going on to bed rest, if this is like definitely in the plan, see if your doctor can actually order for you to have that in your home as like a piece of medical equipment. A lot of times, if you get an order from a doctor, you can actually get that. That's definitely one of the ways you can help prevent. Now, secondly, the pneumonia. We actually expand our lungs, which helps to prevent us from having secretion sit there and develop into pneumonia when we walk around because our diaphragm opens up bigger. So, one of the things you can do to help prevent pneumonia is to get an incentive spirometer. Good old Amazon has one. You can ask your doctor how to use it, but it's really, really easy. And basically, it's a little meter, and you take a deep breath in and you blow out, and then you put it in your mouth and you take a deep breath in, and you're trying to get it to rise. And it's basically expanding your lungs. So those are the reasons why this particular person is probably worried. But there are tons of exercises you can do. In fact, I can't even give you all of them, but some of them include like isometric exercises. This is where you basically tighten and release muscles on your own. You can also do arm and leg extensions, wrist and ankle rotations, arm raises, knee bends, and so much more. One of the things you need to make sure is that you talk to your healthcare provider just to make sure there's nothing there that they're like, I don't think you should do. But most of them are approved. They're very safe. They don't put any pressure onto the pelvis, which is what they're worried about. And it can help keep your body in shape until you deliver. For those of you who are joining me, please feel free to put your questions into the chat. I'm going to go with bleeding. I had a couple questions on the bleeding video. Bleeding is really scary during pregnancy. And actually, we have some questions today on both bleeding during first trimester and bleeding during second trimester. In the first trimester, there's a lot of reasons why you can bleed, and it could be completely normal. Your body might not know yet that you're pregnant. So you might have had a regular menstrual cycle. You might have a subchorionic hemorrhage, which we have a video on, but it's basically a pooling of blood under the placenta. You could have had sex and the vaginal tissue kind of tore a little bit because the hormones for pregnancy thin out vaginal tissue. You might also have a hemorrhoid so that you think that's what's causing the bleeding, and it's really not. So there's a lot of different reasons. And so one of my viewers said, I'm 5 weeks pregnant and now I see that I'm bleeding. Will the baby be all right? I'm scared. The other question I had was, I'm in my 12th week of pregnancy. After intercourse with my partner, I started bleeding a little with small clots occasionally. I've been taking progesterone tablets since week 7 until now. I've only had 2 ultrasound scans at 5 weeks and 7 weeks, which showed everything was okay. Is this normal to bleed after intercourse for 4 days? Let me know. So like, as I just said, it can really be normal. This is something that can happen. But guys, and as we get into second trimester bleeding, it'll be like, this is part of the reason why it's good for you to understand what I'm about to say. Call your healthcare provider. They are there 24 hours a day to take care of you. If you see bleeding and you're not sure, it is best to call them up. One of the things they're going to do is they're going to do an assessment. They're going to check and see what's going on. Most likely the assessment is going to include an ultrasound to check and see what the placenta looks like, what the baby looks like. And they also may do a blood test to see what your pregnancy hormone levels are. So we check in the blood for HCG, human chorionic gonadotropin. And this is the hormone that tells us if you are pregnant. So when you're pregnant, if the pregnancy is going well, it should increase every 3 days. And so if it's doing that, that means the pregnancy is usually going well. If it is not progressing, it actually could mean that the pregnancy is actually going to end in miscarriage, which is, of course, very sad. But it's one of the ways we can tell what's going on. So it's very important for you guys to get assessed if that's happening. And then they can let you know. The other thing I'm going to tell you is, let's say you get checked out and they tell you it is actually normal. It's from intercourse, right? And the bleeding stops. And then 5 days later, you start bleeding again. don't just assume it's the same thing. You need to always just double check with them and make sure they're comfortable with what you're telling them, and don't just assume it's the same cause. Now, when we get into the second trimester, it's a little bit different. So I had 2 questions in the second trimester. One was, I'm 15 weeks pregnant and having light brown discharge with a very small amount of blood clot. What should I do? The other one said, I'm 6 months pregnant and sexually active with my husband. I bleed slightly during intercourse. Is this normal? What should I do? So when we're into the second trimester, we start to look at bleeding and take bleeding more seriously. It's not that it's not serious in the first trimester, but there's a lot of things that we just can't do and can't control. But when we're going into the second trimester, a lot of the causes of bleeding are actually a concern, and they're usually something that needs to get treated. So at that point, we're talking about something that needs to get treated. Now, it could be that you have an infection. So like the viewer that said she's having bleeding after sex, that's the first thing I think of in second trimester. Because if it is vaginal tissue that's thin, that should have been happening all along. So if all of a sudden you're bleeding in the second trimester after sex, then we have to ask ourselves why. So I think infection first. The next thing I think about is a placental issue. So if your placenta is in a different position than we normally expect, and you have some kind of placenta previa, that could cause bleeding. A placenta previa. So the placenta is the organ that feeds your baby. And so it's very vascular on this side. This is the side that attaches to uterine wall. And it's got a whole bunch of blood vessels here, and there's a whole bunch of blood vessels here, and they connect together. And then there's exchange of blood that helps feed your baby and take out toxins. Now, this is usually supposed to be on the side of your uterine wall. Your uterus is like this. It's supposed to be on the side. Your cervix is down here. Cervix is, look, just like this, long, thick, closed. This little slit is almost the perfect representation of what a cervix feels like. And that is where, because a cervix has to be able to open. So it can't be like completely closed. So the mucus plug is here to help protect the uterus from infection. So a placenta previa, a complete previa, your placenta is right on top of that cervix. Okay. So a complete placenta previa is going to end with a C-section. It's an auto C-section. There's nothing you can do. You have to have it. And it's usually done sometimes as early as 32 to 34 weeks of pregnancy. So what happens is, remember, this is all vascular. It's all blood vessels. This is sitting here and you start to dilate, you're going to bleed out. And you can't deliver a baby because the placenta is blocking it. So it becomes a medical emergency for both you and baby. A partial placenta previa is halfway. That is usually also an auto C-section. Low-lying or marginal is sitting right next to it. Okay. And then, so you know, placentas can actually migrate or move. So your uterus starts out small and it expands. So sometimes that that placenta is like at the bottom and it moves up as the uterus expands. But that's another reason why you could be bleeding. And when you have an orgasm during pregnancy, it can cause a little bit of like uterine contractions, which is totally fine. It's for most people, it's fine. But those uterine contractions could potentially, for a placenta previa, cause a little bit of bleeding. So that's why we need to, get it checked out. So we had a question on my water for formula video. So I'm a board certified lactation consultant, but I'm very pro formula. So I have a lot of videos on it because I think families should just have the right to choose what's best for them. And not everybody can breastfeed. That's just not something everybody can do. And it's for a variety of reasons. It can be medical or personal. And so it's really important that we just support people's feeding choices and just make sure babies are healthy. So on this question, she says, I tried to give my baby NAN formula, but she's struggling with constipation. Then I switched to Impicare, but there's no change. What should I do? Please help. I need to stop breastfeeding. She's 2 months old. So One of the things that is, I guess, maybe a disadvantage, you would call it a formula, is that it tends to be more constipating than breastfeeding. Okay. So that is something that actually happens. But it doesn't mean it's always going to constipate a baby. And you can have constipation with a breastfeeding baby. So both of those things can happen. The Impicare is a more broken down kind of formula. So that Impicare actually may be tolerated a little bit better than the NAN formula. But this is one of the things I want you guys to know. So when the baby's first born, we really stress lots of pees, lots of poops. And you'll hear that by the time either your breast milk supply comes in or the baby's 5 to 7 days old, we want to see 8 pees and 8 poops every single day. Every single feed, you're basically changing a diaper. And that is like drilled into your head as a new parent. But the thing is, that's not actually how it's going to be forever. That's actually not the normal pattern. I mean, if you think about us, they're just many human beings. We don't go 8 times a day. So why would we expect them to go 8 times a day forever? We don't. So there is a time where they're going to actually reduce their frequency of stool. They definitely should still be peeing 8 times a day. Again, think of yourself. You are probably peeing 8 times a day, but you are not having stool 8 times a day. So every baby is different when that frequency starts to come down, both breast and formula. Before you assume that it's constipation, figure out if it's actually just normal. Some people feel like it's constipation because the baby hasn't gone in a couple days. That doesn't necessarily mean the baby's constipated. It could just be normal. So having a discussion with your pediatrician is very important because they can help guide you if this is kind of normal for your baby's age or not. Now, some babies will get constipation because their gut flora is a little off. And so you can actually give babies probiotics. Of course, you have to ask the pediatrician just in case there's something going on with your baby, or if your formula has probiotics. Some formulas do, especially European formulas, not so much United States formulas. And I have a video on that. But you want to just double check before you just give it, but that can actually help. So that's another thing. But overall, the Impicare would probably be the better choice. Anybody who's joining me, welcome, welcome. I'm Dr. Samantha here for another one of our live Q&As. Please feel free to put your questions into the chat. I'm currently just answering questions that were on the videos this week. So, I had a question that said, I'm 39 weeks and 5 days pregnant. My cervix started dilating. It's 1.5 centimeters dilated 9 days before my due date. I feel contractions or pressure without pain in my pelvic area, along with mild cramps and back pain. Am I in labor? When will active labor start? So this is a great question because I think this is one of the things that very much confuses a lot of people. They don't know how to tell if they're in labor or not. So unfortunately, guys, you can't always tell. When you're getting cramps or back pain, you should consider that you're actively contracting and that you may be in active labor. Try to see if you can get a timing or a pattern of those kind of backaches or cramping. I can tell you that one day I was in labor and delivery and triage, and I had a first-time mom, and she came in and she was saying, I don't know. I feel a little achy. It's just, I don't know. I'm very uncomfortable. My back is hurting. But she was there looking at her phone. I mean, she really, every once in a while, she'd kind of be like she was uncomfortable. So I checked her to see how dilated she was. And she was 10 centimeters dilated, and she delivered a baby like 5 minutes later. She didn't even look like she was in pain. None of us expected there to be a baby anytime soon. Some people don't have pain. I know that's crazy to sound, but some. And in case any of you guys are asking, her water had broken and she did not realize it because not everybody's water will break and there'll be this big gush. In fact, if you're leaking at the end of your pregnancy, you need to go in and get it checked out. We oftentimes will assume it's urine, and it could actually be amniotic fluid. You can get what's called a high tear. So, this is your uterus, this is the cervix, and you have your sac is down here. But if your sac tears up here at the top, well, the baby's head can settle onto the cervix and it can actually block a big gush of water. And instead, you get like little dribbles. So, if you're having these back pain, cramps, pelvic pressure, you need to assume that you are in labor. You need to call your healthcare provider and they will give you guidance. Some healthcare providers want to see certain symptoms before they have you go to the hospital. Others are going to tell you to go straight in so that they can examine you. And the other thing, in case you guys are wondering, if you're partially dilated and you think you're in labor, oftentimes if you go to the hospital and we check you and say you went from 1.5 centimeters to maybe like 2.5 or 3 centimeters, we might have you walk around the hospital to try to see if we can trigger a more consistent labor pattern and keep you versus just sending you home. So that's another reason to get checked out. Hi, movie mode. Is 6 months okay to try again after having a 24-week miscarriage? Oh my gosh, I am so sorry. Are there signs that can tell you if your uterus has shrunken as my breast and tummy have returned to its normal size? So your uterus should have shrunk back down within 6 weeks. Most people's uteruses, and this is across the board, should shrink back down to its normal size within 6 weeks. And so that's usually the time that most healthcare providers will clear you to go ahead and start trying again. So 6 months afterwards is usually okay. It does depend a little bit on delivery. Most of the time with a 24-week delivery, it can be vaginal and it's usually not traumatic to the cervix or to the vagina. If it was traumatic to the cervix, it's very important to give the cervix a lot of time to heal because otherwise you could have cervical insufficiency where the cervix can prematurely dilate. So that's one of the things that's very important to know about your experience. If you've had a C-section, yes, you are able to go ahead and try to get pregnant again, even that soon, because you should have healed enough. I have to tell you as a healthcare provider, we're supposed to encourage people to wait at least a year because of the whole idea of healing your body. But I understand and I very much empathize with families who've had these very, very traumatic miscarriages because you want to try again. So I think 6 months is really, it's really an okay time. And then here's what I want to say to you guys also as I'm talking about this. If you guys can't tell, I'm a little awkward right now, right? And I'm in psychiatry and I work with women all the time who've had a lot of different types of births, including miscarriages and late term births, late term fetal demises. Sorry. I have been in the room and helped support families with this. And yet, every time I have to talk about it, I am awkward. I am pointing it out because it's important if you ever have somebody in your life that experiences this. It is so important for you to do your best to support them. And it's okay if you don't have the right words. Okay. It's very hard for most of us to even begin to conceptualize what that feels like for that family. And so we all feel a little weird when we talk about it. But if you acknowledge that you may not have the right words, but you're there, it's better. And I always point this out if I ever kind of sound like that, because I think it's important for you guys to realize that you're not the only one. And even myself, who's kind of in the biz, is not able to always like articulate it correctly. So, and I hope I handled that sensitively, movie mode, because I understand it's very, very difficult to go through that. Deborah, I'm aware that pregnant women often have yeast infections. At 27 weeks of pregnancy, what should be the consideration? The OB said we weren't going to treat it since I was asymptomatic, but later provided a prescription for taconazole. However, I've seen many people have experienced miscarriage after, especially in the first pregnancy. My thought is, what's bad for the first trimester is bad for the other trimesters. Be safe. But some sources also say your baby can contract the yeast infection at birth and have thrush. Sorry. Okay, this is a really good one. To be very honest, I have no idea why they didn't treat you in the first trimester. We treat people all the time. A yeast infection is a potential risk in any trimester. And there are medications that are safe during the first trimester that are totally safe to use. Now, one of the things, I mean, I don't know, because the thing is, I was about to say that one of the things I could imagine is they're worried about a yeast infection that's treatment resistant. So all these infections, guys, the viruses, the funguses, the bacteria, they're becoming more and more treatment resistant. We've overused medication too much. So my thought was maybe they were trying to avoid using something if they didn't have to, but frankly, it could have put you at risk for a miscarriage. So I'm not really sure why they wouldn't have treated you in the first trimester, because there's just so many really good meds that you could use. Now, as far as the final, like when you deliver the baby, if you have a yeast infection, yeah, it could happen. They might get thrush. They might not. They oftentimes get thrush for other reasons, but I'm not sure. I would tell you it should be treated no matter what some like trimester it is. It needs to be treated. It's a risk. So I hope that answered your question. That's odd. That's a weird one for me. Okay, so I had a question on the drying up milk video. And I don't think it was meant to be here, but I don't know. I've been breastfeeding for over 4 months now, and I don't want to stop. Please, what should I do? So I think this person means that they want to stop, and I'm not sure. So I would say that drying up milk, the video is a really good way to look at it. There's a lot of homeopathic stuff, but ice, cabbage leaves, and peppermint are my 3 favorite. There is a medication that's often prescribed to women when they're trying to dry up their milk. It's called cabergoline. Cabergoline, it's the other name for it is bromocriptine, is absolutely the worst medication ever. I wish nobody would give it to a postpartum woman ever. So cabergoline, very effective at drying up milk. That's the problem. So OBGYNs give it out a lot because it really does work. The other thing with cabergoline is it boosts up dopamine, and dopamine is the feel-good hormone, feel-good hormone. It's like what makes you happy. So you take cabergoline and it dries up your milk and you feel amazing. And then after 10 days, you have to stop. And then your mood tanks. So imagine you're hormonal, you're stopping breastfeeding or stopping producing milk, and now your mood is tanked to nothing. And it can cause severe rebound depression, including postpartum depression. So one of the things I'll tell you guys is if you are prescribed cabergoline to dry up your milk, I would not take it. There's so many other things you can use. Now, if this person meant that their milk was drying up and they didn't want it to dry up, it's important to go ahead and there's like different herbs you can take to boost your milk supply. And one of the biggest things is demand. So that's where we usually suggest that you use a pump and you're pumping regularly. Check your baby for a tongue tie. Tongue-tied babies are oftentimes not able to stimulate the breasts good enough to keep up a milk supply. So depending on what it is, that's kind of where I would go with either one. But drying up milk is one of the things that I take very seriously, because when you're done, you need to be able to figure out how to dry up the milk quickly. And it's very important to do that, and also not to develop stuff like mastitis or anything. So, that's why we do it. So I hope that answered that person's question. Okay. I had one on my partner support. So I am a big advocate for partners as well. Part of my doctoral project was on postpartum depression in fathers. When we're talking about pregnancy and postpartum, the woman is the show, she's the star. That's what we all focus on. But the thing is, her main support person, her partner, If they're not supported as well, then the whole system breaks down, because she does need a lot of help. Like, she absolutely needs a lot of help. But how many times do we hear you can't pour from an empty cup, or you put on your mask first, right? So you have to make sure your partner is also being supported. And it doesn't have to mean that they're out 24/7, but even allowing them a little bit of time to be able to recharge is so essential. So I have a lot of videos. And so this partner support it's like a video on how to support your pregnant partner, right? And so the comment was, my wife is pregnant and she always feels angry when she sees me. What should I do? So this is really, really hard. And unfortunately, it does happen. So one of the things that can happen is there can actually be some resentment. Pregnant people will oftentimes resent their partners because their partners aren't getting morning sickness. Their partners aren't getting heavier and growing out of their clothes. Their partners aren't getting stretch marks or acne or all these other fun things that happen with pregnancy. And it creates this feeling where there's a lot of resentment. A lot of pregnant people, like our viewer who's going to be on bed rest, she's not going to be able to do a whole bunch of stuff. And there's a lot of jealousy and stuff that comes with that. And so that's where it can start. So the first thing you need to do is you need to make sure you, the partner, have a good outlet, somebody that you can talk to. A therapist would be ideal, because then you're not like sharing your business with like friends and family who might like make everything more challenging. But you definitely want to make sure that you're getting the support you need, that you're being able to do stuff for yourself, and then just keep being nice. Listen to your wife. If she is asking for space, you give her space. If she's asking for help, just try your best. It will hopefully pass, but unfortunately, it can be very common. And it's okay to advocate for yourself. Okay. Everybody should be able to advocate for themselves. If you feel like somebody's not being nice to you, it's okay to say something. You just say it gently, say it really kindly. So, the other thing is, I'm a very big advocate of pregnant couples starting to do marriage counseling or couples counseling. Couples counseling is extremely important, because once that baby comes, everything gets all like crazy all at once. And it's really important to have good communication leading into that time. After my miscarriage, yes, my breasts were very engorged, and they prescribed that same drug to dry up my milk. Luckily, it was not on the island, so I didn't have anything to use. However, I tried maca root. After the maca root, the next day, my breasts reduced and there was no pain, and the milk drained lightly and then disappeared. Yes. Okay, so I love this. I'm going to research this afterwards, but this is what's amazing about everybody coming from different cultures. So absolutely movie mode. Absolutely. It could have been the maca root, 100%. And that's what's so amazing about us sharing our knowledge. There's so many natural things. And now this is not drying up milk. This is increasing milk, but I'm in South Florida. So we're in the Caribbean, right? So we have all these people from all these Caribbean islands, and it is so common to see Haitian women and Jamaican women come into the hospital with this soda that we call Malta. It's disgusting. It's awful, but it's malt soda. And that malt is actually, they take it because it helps to build their milk supply. And there's a lot of evidence with that. If you look at some of the lactation cookies, they often have brewer's yeast and other things that you find in beers. Over in Europe, it's very common for women to be encouraged to drink beer to help increase their milk supply. So that Malta soda, which a lot of people like, I just don't like it, but it helps to boost their milk. And then my producer just said it's delicious. And then there's also another person. I think they were from Nigeria. They brought in lentil soup, and they were saying the lentils, which are high in iron, so very good for you, actually help to boost milk supply. So these are coming from different cultures and what they had in their areas to help to do that stuff. So absolutely movie mode, absolutely the maca root, absolutely could have done it. And I'm going to actually look it up to see if I can understand what chemicals are in it to actually do that. Shady Pines. My niece is 36 weeks, almost 37 weeks pregnant, and her baby is breech. She also has a lot of amniotic fluid, more than normal, and she also has a septated uterus. She's worried. She's worried about the extra fluid. She's wondering if she's going to need to have an early delivery. So I don't see any reason they would do an early delivery, but my guess is with all of that, they're definitely going to do a C-section. They may try to do it at 39 weeks. So we're trying not to induce anybody prior to 39 weeks. If we can keep you pregnant, we're going to keep you pregnant because there's a lot of brain development that happens between 37 and 39 weeks. And that brain development is related to temperature control. It's related to suck swallow coordination, and it's related to like sugar control. It's also related to like glucose levels, and then you have extra fat that's going on to the baby during that time, so it helps with hypoglycemia. So it's really important to stay pregnant as late as we can. Extra fluid is a big deal, guys, because there is a risk of a cord prolapse. So I actually have a video on it. It's called polyhydramnios is the name of that condition. And polyhydramnios, when you have too much fluid, the baby's sitting up and high. So sometimes your cervix won't dilate because you don't have enough pressure on the cervix. But the other thing is because your baby's floating up, when the water breaks, sometimes the cord will slip down in front of the baby's head, and that's a medical emergency. A septated uterus is a different shaped uterus, and so those are oftentimes C-sections. So my guess is she's going to need to have a C-section in general. You will hear some people say that their doctor will deliver breech babies, okay? I have seen breech deliveries. I have worked with physicians who are comfortable with breech deliveries. Breech deliveries can be, there's my cat, say hi to my cat. Breech deliveries can be very traumatic to baby, but more mom. So there are different tears that can happen. And a lot of times, like a 3rd or 4th degree tear can happen with a breech delivery. So a 4th degree tear, you're actually tearing from the vagina all the way to the anus. And it actually requires you to go back into surgery to get sewn up. So it's a big deal. So again, I would imagine with all of that going on that they're probably going to do a C-section. If they do a C-section, that should prevent the cord prolapse because they'll hopefully like schedule it and it'll all be set. So yeah, I wouldn't worry about it because at this point it's just there. So burn. Okay. Will the milk dry up without meds, or you definitely have to, you're welcome, or will you definitely have to take meds to dry up your milk? Okay. So you don't definitely have to take meds. A lot of people take meds because they want to get it dried up fast. That is especially important for somebody who's had a miscarriage, for example. You just want the milk done. There are women who have to go back to work and they can't afford to get like a mastitis or something like that. So everybody's different. You can dry up your milk by simply tapering off of breastfeeding or tapering off of pumping. Like that's a very valid way to do it. But most people, it seems like they're done and they want it dried up. So that's why we talk about meds and herbs all the time. But there's a lot of homeopathic stuff. Like I said, you can do cabbage leaves, which has been used for like hundreds of years. You can do ice. Ice is also very good. Supportive bra, but not binding the breasts. So it used to be that they would bind the breast and put a lot of pressure. You actually don't want to do that. That can actually lead to more complications. You also don't want to use a tight sports bra, but you do want to have support on your breast because that helps. When you take a shower, warm water on the back, not so much on the front because warm stimulates milk. And my favorite is peppermint. So actually peppermint oil deodorant, like right here, you've got like the start of the ducts. It'll dry up. It'll dry up milk very easily. So that's like one of the things I recommend. So kind of going into so we had the question from Sandy Pines, and I was talking about C-section. So I'm going to answer this next one. Is there a risk with a fourth C-section? So yes, I wish I could just say you're welcome. I wish I could just say no, but unfortunately, I have to say yes. So C-sections are major surgery. Okay. They are no joke and they are real births. So anybody who tries to shame you that you didn't have a real birth, they are a joke because a C-section is really hard work. So there's two different incisions that happen. And that's the starting point of what you need to understand about risk. So there's an incision on the outside. It's usually that low bikini cut, I'm going to be so cute afterwards incision. It's usually very small, and it's amazing how they take this small incision and they get a baby out of it. It's amazing. They go through layers until they get to your uterus. Now, once they're at your uterus, just because on the outside they had a horizontal incision does not mean the uterus has that same incision. So inside, the uterus could have a horizontal or it could have a vertical. A vertical incision is a lot higher risk for a lot of complications. So they try not to use a vertical incision unless they absolutely have to. Now, when you have repeated C-sections, they're going to try to go through the same scars, okay? They're going to try to use those same outlets. But of course, that creates a weakened area in the uterus. Now, the thing is, you don't want to make multiple weakened areas. That's why they're going into the same spot. But this puts you at risk for what's called a uterine rupture. So a uterine rupture, what happens is you're in labor, you're feeling labor pains, and actually you can start to get more and more pain. And then all of a sudden, what most women will describe is they describe pop and there's no more pain. If we have a woman who's in active labor who says there was a pop and no more pain, we are rushing her to a C-section. That is a medical emergency, and it is most likely a uterine rupture. Uterine ruptures are extremely rare if you've never had uterine surgery. So any of you guys who've never had any C-section or anything like that, don't start worrying that's going to happen to you. I mean, it's like 1%, less than 1%. But once you've had a uterine surgery, then you become more at risk. Now, the next thing that can happen is you can get adhesions. So adhesions are like scar tissue. So every time they're going in there, you have a higher risk of internal scar tissue. And that internal scar tissue can attach to other organs like your bowel, like your ovary, like your bladder. So unfortunately, they have to cut through those adhesions to get to the uterus sometimes. And when they're cutting, it puts you at risk for injury to the rectum or the bowel or the bladder. So that's another thing. And then you're at risk for a hemorrhage. The uterus, every time it expands, those muscles are stretching and it's harder and harder for it to contract back down. That contracting back down and going back to original size prevents a hemorrhage. That's what's saving your life afterwards. So when we're stretching that out, it becomes harder and harder for it to do your job. So we're at risk for that. And then finally, I talked about the uterine incision and how you could get you could have like a uterine rupture where it pops open. Now we're talking about the outside. So the outside has also been stitched and you've gone through those layers. So you can actually develop a weakened spot there and develop a hernia, which is actually an area of that where you still have skin over it, but the muscle underneath actually opens up and you can have stuff like your intestines slip through, which can also be. So, I mean, there are risks. Now, when we talk about baby spacing, like I've said this before, you can go onto the WHO. There's a big deal on baby spacing. And then what that means is you don't get pregnant right away. You give your body a chance to heal. When you do that, especially after C-section, you allow the uterus more time to really get strong again because it can do that. But C-section after C-section after C-section is a much higher risk. Okay, can ovulation be identified by changes in the body's temperature? I noticed after my miscarriage, I'm now heading into my second week of healing and my body temperature at times changes to hot. Yeah, normal. Can this be ovulation? Yes, it can absolutely be ovulation. In fact, that's a natural family planning method that you take your temperature every single morning, and the days that you notice all of a sudden there's a slight temperature increase, that's usually ovulation. Also, if you track your cycle, you can start to figure out you'll probably ovulate about 13 to 14 days, maybe afterwards, maybe 11 to 13 days after the start of your period. The other thing, guys, definitely not as scientific, but actually really semi-accurate. And I was talking to a woman today. Usually around the time of ovulation, your libido will increase. You will actually feel more like having sex. The reason for this is, as human beings, ultimately, we're designed to procreate and have little human beings so that the human species survives. Because if we don't do that, human beings will cease to exist. So if we don't feel like having sex, we're not going to get pregnant. So oftentimes around ovulation, you'll actually have an increase in libido, and that's kind of normal for the hormones that are there. Also, why does the body seem a bit more fertile after a miscarriage? My OB keeps asking me to be careful, but I'm at a place I really don't care. Once it passes 6 months, I'm ready to try again. So, again, I'm going to go with not really scientific. I've seen some stuff with it, but not a lot. So it is very common for women to report after their first pregnancy that things that were a problem before are no longer a problem. A very specific thing is HPV. A lot of people will report that their HPV symptoms disappear. And it has to do, I think, with the fact that you get all these really good hormones. The other thing you'll find is that a lot of people had infertility, right? There's even people with IVF and all this stuff, and they have a baby and they just assume they're not going to be able to get pregnant again. And boom, they get pregnant 2 months later, because something about it's like it jumpstarts your body to understand what it's supposed to do. It's supposed to get pregnant. It's supposed to do all these things. And now it's ready. The same phenomena happens with breastfeeding and breast milk production. So a lot of times, first time moms, they do not produce that much breast milk. They don't produce as much breast milk quickly. Like their body doesn't know what to do. But then second time around, they'll produce so much breast milk. And it's because their body learned what to do during the first baby, and then they're figuring out what to do in the second baby. And then after the bleeding passes, after bleeding passes after birth, when does the monthly cycle likely to return? That is a trick, okay? Because unfortunately, with that, we don't always know. It can be right away, and it might be 6 months, 8 months. It's hard to say. Now, I'm very careful with this because so many women have a surprise pregnancy after they give birth, because what they don't realize is you can have silent ovulation. So what is silent ovulation? That means you are releasing an egg and not having a period. Okay. So when your body's getting back into gear after you've had a pregnancy or a birth or a baby, your body's hormones have to readjust and regulate, which is probably why you're noticing some of the changes that you are movie mode. And a lot of people do. So your body's got to figure it out. But you can start releasing eggs that can be fertilized. So don't assume that just because you haven't gotten a period, you aren't ovulating. In fact, most people will ovulate before they get their first period. It makes sense. That's what triggers the period. So it really is hard to say sometimes. Okay, I'm glad to hear that. So is C-section recommended for women with very high myopia? So I am going to say I don't know, because myopia doesn't seem to be the right word, because myopia is nearsightedness. So I'm thinking that's not the right word. So if you're able to put that in, let me know. I have one more question on my side. So any of you guys get your last minute questions in. The question I have was on my depression and pregnancy video. So it said, I'm taking venlafaxine, 37.5 milligrams once daily, and clonazepam, zero point 0.5 milligrams nightly since 2020. Now I'm 4 months pregnant and still taking this medicine daily at night. Can you please tell me if it's safe for the baby? So I work in psychiatry now. I decided to go into psychiatry to specifically help women who are pregnant and postpartum, as well as dads with postpartum depression. It's a area that's not very well supported in psychiatry, and it was really something that I felt very strongly about. So I definitely prescribe meds all the time. So venlafaxine is also called Effexor. It is an SNRI, serotonin norepinephrine reuptake inhibitor. So SNRIs are generally speaking safe. They don't have as much data as SSRIs, which are like Prozac and Zoloft and stuff, but they do have a fair amount to be looking at as like a safety thing. So venlafaxine is usually considered safe for pregnancy. I have women on it from first trimester. And there's no reason for us to believe that it'll cause any kinds of birth defects. But venlafaxine is a little interesting. There has been a lot of kind of stuff looked at where it has a higher chance of withdrawal syndrome in the baby. So withdrawal syndrome in the baby is common with a lot of these drugs. So your baby's going to get some of these drugs in through the placenta. Well, guess what? These antidepressants, they make you feel good and they make baby feel good. So it's good for the baby at the beginning. But then what happens is when you deliver and the placenta detaches, they immediately go cold turkey on these meds. So that, of course, is going to make the baby not feel so good. Neonatal withdrawal syndrome from SSRIs and SNRIs, it sounds really scary. It's not what you imagine. It's oftentimes a baby who's irritable, shaky, might cry a little bit more, but generally speaking, it goes away within a couple days. It may not even happen. You give that baby lots of love and, feed them often, and it'll usually help. Breastfeeding, if you actually continue to take the medication, they'll get little bits in the breast milk. That can actually help wean them off naturally as well. Now, one of the things we'll do sometimes when a woman's at the end of her pregnancy, if she's stable, is we'll actually reduce the amount of medication that she's taking and then bump it back up afterwards to try to give the baby a little bit less. Venlafaxine happens to have a higher chance of that. Now, clonazepam. So clonazepam is a benzodiazepine. It's also called Klonopin. And Klonopin, as all of the benzodiazepines, are really not something we recommend during pregnancy. I actually don't like to prescribe them at all to anybody. So these are highly addictive substances, and they will transfer through to the baby, and the babies will test positive for it. Now, these medications are really good for very specific circumstances. I mean, they're great for anxiety. They're great for panic. I mean, they really work. But if you take it over time, you can develop tolerance and addiction, even if you're not misusing it. Well, baby's having the same experience. But here's the thing. When you take Klonopin or Xanax or lorazepam or Ativan, any of these benzodiazepines, if you take it and you've been taking it for a long time and you immediately cold turkey stop, you're at high risk for seizures. So all these meds actually also help treat seizures. We don't use them long-term for seizures, but for short-term, like if somebody's like having something like that, we will use it for that. So the thing is, if I just told you, you stop cold turkey and you're at risk for seizures, what's going to happen when that placenta detaches? Baby goes cold turkey. So a lot of times these babies are ending up to having to go to the NICU, the neonatal intensive care unit, so that we can monitor them to make sure that they're safe and they don't have a seizure. So if you're able to do so, it is really best to try to get off of that before the third trimester. That would be the ideal thing. There's a lot of different medications that can be used. And there's homeopathic stuff like magnesium or B6. There's stuff like Buspar. You could even do gabapentin or Benadryl, hydroxyzine. There's so many options that are probably going to be safer profile, but you cannot just stop. Let me say that again. You guys, there are medications you cannot just stop because you put yourself at risk for a seizure. And if you have a seizure while you're pregnant, that's life-threatening for the baby. So it's really important to have an active conversation with your healthcare provider on how you can switch that out for something else. Can preeclampsia occur with barely any symptoms? When should you get worried and contact your doctor regarding that? So I'm going to go yes, Ramonte, because I think preeclampsia is way more prevalent than they're saying. So first things first, you need to know blood pressure guidelines. The blood pressure guidelines are not what you imagine. If your blood pressure is over 120 or over 80, that's basically considered hypertension. So that's the starting point. People have a lot of hidden hypertension that's not acknowledged. The second thing is there's a lot of symptoms that go along with it, and like headache, like visual symptoms and other things. And those symptoms, I think, can be early warning signs for preeclampsia. Now, that being said, one of the things you guys should know, a lot of people wonder why they have to go to the doctor so often, especially when they'll say, all I seem to do is talk to them for 5 minutes and pee in a cup. That peeing in a cup and the vital signs they do are the two most important things in your pregnancy. So every time you're going, that is extremely important, okay? Because the vital signs give us an early warning sign for preeclampsia. And when we're checking your urine, we're checking for two things. We're checking for protein and we're checking for sugar, ketones. If we see ketones, we are now suspecting diabetes. And if we see protein, we're expecting like kidney issues, which is usually preeclampsia. So it's something that is very, very important to check. The other thing is hot, kind of pain, weird pain on the right side. That can also be like a big thing. But I do believe that there's a lot of early signs that are happening that we're just disregarding. And then unfortunately, women are kind of heading into it a little too late. So, I would always bring it up to their attention. The other thing is swelling. Oh my gosh, guys. A lot of times they'll want like all this swelling all of a sudden, but I can't tell you how many of my patients, a lot of them I see on camera even, and I'll be like, man, you look swollen. And they'll be like, oh, I told the doctor, and then a week later they have preeclampsia. So look at the swelling also. But if you're never sure, please ask them. It's really important for you to do that. So now my last question, and thank you for clarifying because I really wasn't sure, but I'm glad you clarified. So myopia is nearsightedness, and this is what Yenlik was referring to. So I have very high power of nearsightedness, power of -12. Is it possible to give birth naturally, or is a C-section recommended? No, you can absolutely. You're welcome, Ramonte. You can absolutely give birth naturally. This is not an automatic C-section. I suspect that what you may have heard and what the biggest thing is that of retinal detachment. So what happens when you're giving birth is in order to bear down to push, you have to like basically like you push internally. You create this like pressure internally to push the baby out. But when you're doing that, it also increases your intracranial pressure, which puts pressure on your eyes. And that pressure, the worry that some people have is that you could. It's very rare, but it is theoretically possible. But that does not mean an automatic C-section. I would definitely talk to your healthcare provider, but they should be able to give you that option. But the other thing I would be doing is I would be talking to your ophthalmologist. I always think about optometrist or ophthalmologist. I would talk to your ophthalmologist. I would actually have a consult during pregnancy and talk to them about their thoughts and feelings on delivery naturally versus C-section. And then finally, I would tell you to please look into your pain management options. Okay. Pain is it causes us to tense and stress and create different like muscular movements that could increase pressure. So what you definitely want to do is know how you feel about pain management. And if you're like pro epidural, like ask for it when you're ready. Don't wait until the end, because that can also help to like, relax you during birth. And if you don't want to use anything and you're going natural and everybody's on board, look into hypnobirthing. Hypnobirthing is like amazing. And it really can help you get into a really good, peaceful place for your delivery. And with that, I am at the end, but I promised you guys that I would give you a sneak peek on tomorrow's video. So make sure you like and subscribe and hit the notification bell, because then you will know when my new stuff comes out. So tomorrow's video is on post-weaning depression. So it is very common after somebody stops breastfeeding or stops pumping and dries up their milk to actually have a rebound depression that will oftentimes look like postpartum depression and can actually not be postpartum depression, but instead post-weaning depression. So I have it out, it's there, and I really feel strongly about giving you that information. So I hope you will enjoy. My name is Dr. Samantha. I am the maternity mentor. I'm here every Monday at 9 p.m. Eastern Standard Time to answer your questions live. Also, you can put your questions over on the videos in the comment section. We read them, we look at them. I'm the one typing out those answers. Occasionally my producer, AKA my husband, does, but most of the time it's me. So I am really reading those. I love to interact with you guys, and I really appreciate all of you guys for being here. Thank you so much. Have a good night. Talk to you later. Bye.